Now we're going to talk about cost-benefit analysis, and it was usually used to look at new programs, and whether they were better than no program, right? So it's usually compared to non-existing things. In farm economics, it's not about social policy, it's really about new drugs is when it's really used, actually, to see if a new drug is beneficial to what's already being done, or if you do an asthma prevention clinic in a location, does it add value? One of the constraints, however, is that with this model, it only and reduces everything to dollars. It is all about the money. And that is one of the benefits and one of the problems. So it actually looks at, because it's a benefit, because when you're doing statistics, if you all have the same monetary or the same unit of analysis, which in this case is monetary with dollar bills, then it does make it easier to compare sort of apples to apples, oranges to oranges, and vice versa, right? In this case, it would be the apple is an existing drug versus a new drug, which could be an orange, right? So you could do that because everything is evaluated the same way with dollar bills. And it really does help to see if it offers good value for society too, in the sense of it allows the money being spent on one program and one drug, does it generate enough benefits financially or for the society as a whole, right? A net benefit. So it's benefits versus costs, and benefit cost ratio is how we talk about it. And it's really about guiding resources, right? And one of the things that it does, unlike some of the other things that we've talked about, which is cost effectiveness evaluation or cost utility, we'll talk about those later, is that it uses natural units, right? So it looks and monetizes dollar amounts with health outcomes. So that values things like life, reduction in pain, and increased productivity in dollars, okay? The benefit is it assesses overall societal worth comparing to health interventions versus not intervening, right? Now, typically it was used with like education versus not education, housing versus not access to housing. The inputs, however, are direct costs. So it's like the drug price, the number of days on hospital stays, the money that it costs, right? Their indirect costs would be lost wages. Monetary benefits would be you averted certain medical costs that would come along with not using the drug. You'd improve quality of life, and those are called the quals, just to let you know. And productivity is usually valued about based on your wages, right? It's not just a general number, although you can standardize it to $150,000 in America per wage, or in less resource countries, you could do it as part of their GDP. So again, you can still monetize everything. The calculation is determines if a project or a drug is worthwhile by seeing if the total benefits in dollars exceeds the total cost in dollars, okay? And you use it to assess new drugs, new drug programs like an asthma clinic, like we talked about previously, or policies comparing an alternative to see if the investment gets you a net positive investment. And the formulation and the concepts are net benefit equals total monetary benefits minus total monetary costs. So it's very simple in that way. But everything, including things like hospital stays and number of days that you lose from work, has to be made in monetary valuations. The benefits versus cost ratio equals total monetary benefits and then total monetary costs, right? So it's got to be the cost has to be less than the benefits, or else it's not seen as cost benefit analysis worthy, right? It's really, really helpful though when you're trying to justify funds or allocating resources to a new entity, when you're trying to compare the economic impact of something. So you've seen this with Ozempic, where they try to compare the economic impact of people who don't have issues with their weight, what impact it has on diabetes, hypertension, other things, and that would be part of the calculation, days they lost from work based on those illnesses, those chronic illnesses, right? It does allow for a really broad comparison among different sectors. It's not a comparison of like drugs. That's cost minimization, right? It's not that. It is looking at this versus that, right? The problem is that it has lots of challenges, right? And some of the challenges there are things like intangible benefits, like reduction in pain. Now, yes, you can reduce that to a dollar amount, but it gets a little bit trickier versus how much money you can make, days lost from work, that could be reduced into money, hospital stays reduced into money. But pain is a little bit more difficult, and it requires really careful consideration of what is a cost and what is a benefit, right, over time, because you have to discount, right? Discounting is the cost of something now versus in the future. That's inflation. But also, when you save for things like retirement, you're not doing without a little bit now, but the benefit of that money later is going to be much greater, right? So that's very difficult to sort of build in. It also has an income bias, right? So the method really does favor those with higher wages and productivity, right? So, it's more important to give people who make $250,000 a year a medication because they're going to make that much more money, right? So it might be beneficial for certain segments of the population and not others, which is also kind of weird. That inequality is built in. And that's not such a good thing at all. It's really hard to, as we said before, talk about things like quality of life. All you can do is talk about money not lost from working. So that's a little bit difficult. Quantitative intangibles is what we call them. What the patient prefers, money just sort of says you prefer to work. And we frame it that way. And we don't always reflect what the patient really wants or needs in the society. So again, it's that inequality, that differential in how we measure things, the beyond money or in addition to money that impact money. But we don't measure those. Unless we can do money, we're not going to include them. It's really difficult to use things like we just talked about previously, that discounting effect. What is the impact of you being in perfect health now versus later? What costs are those? And the data is very difficult too, right? Again, and it feeds back to the one thing we've already talked about, which is how much on average someone makes versus how much you make, right? So, you may save money, you may save time, but it may not be applicable to other people. And other places, right? And we talked about how that cost of illness is very specific to place. This is sort of looking at a wider swath and assigning money to it. So there's even less nuance. The market is really imperfect in healthcare, right? You can have the cost of one hospital in one place a lot, and then the benefits could also be hard to measure in things like public health, right? So cost-benefit analysis would be giving immunizations versus not. Well, you could look at people would die. That's a negative. But how quickly would they die, right? So when we look at immunizations and we look at immunizing children, the small amount we're putting there, we're going to get long-term, really big discount impacts monetarily, right? Because then they're never going to get sick or they're going to have less days sick. If it's someone who's 80 years old and they're not working and we have to put in a whole lot of money into them and they're not producing monetary benefits, then it's a little bit more skewed and a little harder to determine, right? A little bit harder to determine with kids too, because for a range of that, they're not going to be making money, right? And again, we're measuring not just years of life, but economic benefits, okay? It really does, because of the way it measures things, it distorts the impact of innovations, right? So it looks at high-priced conditions, such as chronic illnesses like we have in the United States, so diabetes, hypertension, things like that, cancer if you're young, right? And you're going to put the money in towards that because the cost benefit is going to be greater. You're going to get more funding for that. You're going to get more of a market for that versus diseases that very few people get, diseases that happen only when people are older or really, really young. So that built-in bias sort of builds on itself in that way. And innovation for certain illnesses is automatically going to save more money because more people have it. Again, that cost of illness comes back into play. I told you all these sort of build in to each other. We also have to look at there's got to be a universal, that it's qualified, right? So we can't just do an arbitrary number. We have to have sort of a standardized number. And in this we do. We'll talk later in other things about quality of life is worth a certain amount. Average income someone earns in a profession is worth a certain amount. So there are some ways to quantify it with the dollar, but then it also builds in that sort of bias too. Also, it really is hard to assess the cost of how unequal outcomes might happen versus, like you might have blood pressure issues versus other issues, right? So unless you're converting into monetary value, which again makes assumptions, having hypertension versus cancer is really hard to sort of factor into this situation. All you can say is it depends on the age you get it and how much money you make, right? So again, it's very reductive and it doesn't show the whole picture. That's why we have other ways that we sort of try to address those things, like cost effectiveness analysis, which we'll see later. But it really does make it a useful tool, but only if we're looking at certain things, and we have to understand those biases are built in.